steps during break. And that's good. It's good to get your brain going. Okay, questions from what we covered in the last hour. Okay, then let's start with the diabetes and talk about the different types of diabetes that there are. So, glucose homeostasis is tightly regulated by the body. It's very important to the body that it hangs on to all the energy it consumes. So you can see that 1,000 years ago, even today, in some areas of the world, fuel is not abundant. So when it is abundant, you want to be able to store it away, and when it's available, you want to be able to use it. So we don't waste energy. So anytime you find sugar where it should not be, like in the urine, there is something wrong. So high blood sugar or sugar in the urine is never normal. So the basis of all diabetes, every type, is high blood sugar. So hyperglycemia is the common denominator in all types of diabetes. It results either from a defect in insulin secretion, which can be absolute deficiency to a relative deficiency. It can be due to insulin's action. Maybe it is rarely that there is something wrong with the insulin, but there can be a receptor defect. So the receptor that sits on the cell wall can be defective, or the chain of events that it sets out in the cell, the signal transference or transduction, can be an error. Okay, so there's multiple places where things can go wrong. Or it can be both. Both can exist. By the time you see most people with type 2 diabetes, both of those things are already in place. So the insulin action is abnormal. Insulin production is coming from a dysfunctional beta cell that no longer reproduces it or secretes it in a pattern that fits the intake of the diet. So that causes its own symptoms acutely. And those are the ones we've talked about: polyuria, polydipsia, polyphagia. Those are acute symptoms of hyperglycemia. The long term is that when sugar stays around in levels that are higher than it was intended for long periods of time, then we start to glycate proteins, basement membranes in particular. Then that becomes a problem because that starts to disrupt the organ's original function. So it leads to complications. So long-term damage, dysfunction, failure of various organs, especially the eyes, the kidneys, the nerves, and the heart and blood vessels are the main complications. Diabetes affects every part of your body. These are the organs that tend to be the most commonly affected and fail. So people don't die of diabetes, they usually die of the complications of diabetes. There's a lot we know now from large studies that what we can do to prevent or delay or slow down the progression of those complications. So it's really important to convey to people who have diabetes that day-to-day care and the best blood sugar they can obtain in a day is an important goal. Because those complications usually don't show up for about 15 to 20 years. I often thought if diabetes was more like cancer, that it killed you quickly, it would get more press or more attention. And it does get a lot of attention, but it is a slow disease, and it's a frustrating disease for providers to deal with. Because it's hard. It's a hard disease to have. It affects everything you do to some degree. And so it's hard for people, especially when they get it as an adult, to change the way they have always done things. So it's a hard disease for them. It's hard for people to care for them. Okay. So that's the definition of diabetes. If we look at classifications, there's two primary ones. There's type 1, there's type 2. The predominant one is type 2 in this country. About 95% of people who have diabetes have type 2 diabetes. Type 1, to a much lesser extent. So type 1, and they're different. In terms of their what causes them, it's different. But the common denominator comes down to high blood sugar. So, let me take this off because I'm distracted. So despite how we get to hyperglycemia, in the end, it's the same. Okay? Doesn't matter how it came about. The symptoms and the complications are going to be the same. They may occur in different percentages, or likelihood may be different in type 1 and type 2, but in the end, the hyperglycemia will lead to damage if it is too high for too long. The type 2 is predominantly comes from insulin resistance and beta cell dysfunction over time. So they're very different. Type 2 tends to be very much influenced by genetics, type 1 to a much lesser extent. So specific types, there are other types. There are defects in beta cell function, defects in insulin action. Those are more rare. Diseases of the exocrine pancreas. So people who have frequent bouts of pancreatitis can eventually decrease their insulin producing capacity in the endocrine portion of the pancreas. Trauma. If you've had blunt injury to the pancreas and part of it's had to be removed, so pancreatectomies, depending on what part of the pancreas they had to remove, can lead to diabetes. So most of the beta cells are in what part of the pancreas? No. So the pancreas kind of looks like this. Okay. So this is the head, this is the tail. So the head butts up against what? Duodenum, or the duodenum. Okay. And this sits right behind the stomach. So which is the exocrine part, which is the endocrine part? So what's the difference? What's the difference between an exocrine function and an endocrine function? Okay, so exocrine, she said, goes to the intestines, endocrine goes to the blood. That's true, but they involve ducts, right? Exocrine secretes theirs through a duct, and endocrine directly into the bloodstream. So this is the exocrine portion of the pancreas. Makes sense, doesn't it? It sits right next to the small intestines. It produces a lot of the digestive material you need to break down foods to their final building blocks. The tail is the endocrine portion. So most of the beta cells, islets, the islets of Langerhans, all are out in this tail region. You're born with about 1 million of them. Okay? They're hard to regenerate. You can to some extent, but pretty much if you lose them rapidly, you cannot reproduce them or replace them. So if you have injury to the pancreas, if you have to have part of it removed and it's removing mostly tail, then you've lost a lot of endocrine function. Cancer, same thing. Cancer of the pancreas, depending on what part, can lead to diabetes. Cystic fibrosis frequently is associated with diabetes in kids. Endocrinopathy, so acromegaly, so defects in growth hormone production. Remember, it's a counter-regulatory hormone, so if you mess it up, diabetes is a common concomitant disease. Cushing syndrome, overproduction of cortisol, again, another counter-regulatory hormone, can cause diabetes as well. Hyperthyroidism, we can see glucose changes in glucose metabolism. Pheochromocytoma also. Some of the drugs can cause diabetes. Probably the most of these, it's the AIDS drugs and the transplant drugs that cause the most, have the most impact. The rest of these are to smaller extents. So we'll see when we have patients who have HIV infections that are on antiretrovirals, we have to check them about every 3 months for the development of diabetes. A lot of the transplant medications to keep someone from rejecting an organ will cause diabetes. Infections, congenital rubella, cytomegalovirus, these have been implicated in the production of type 1 diabetes in susceptible individuals. Genetic syndromes, Downs, Klinefelter's, Prader-Willi, Huntington's chorea, these often they'll have type 1. I saw a lot of these children as adults in my practice with especially Down syndrome. Okay. Questions about those? So many types. Many of them, those other types at the bottom tend to be secondary. You get the diabetes secondary to some other disease or drug. The other two are more primary. It's usually a defect that has occurred that's primary and not secondary to some other cause. Okay, gestational diabetes. So we hit a little bit of this in OB. So gestational is diabetes that is first diagnosed during pregnancy. Occurs in about 7% of pregnancies. This is usually happening to someone who already has a predisposition. So you're putting a large burden on the body. It's also a lot of the hormones in pregnancy are insulin resistant. And so we will see in later pregnancy diabetes developing. We almost universally screen all pregnant women between the weeks 24 and 28 weeks gestation for this. The main problem are immediate in terms of delivery of large babies and some of the problems that can occur to the baby we'll talk about. The other is that it's very important to let these women know is that you need to be tested now on a regular basis, because usually in 10 to 15 years, 75% of those women will have type 2 diabetes. So it's kind of like a warning. You put a major stressor on that system and it showed up. Usually when they deliver, it goes away. Their blood sugar metabolism will go back to normal, because you've removed an insulin resistant state. Okay, looking at epidemiology. So about 10% of the adult population has diabetes. About another 3% are thought to be undiagnosed. When I was at your place in training, it was thought to be about 50-50. So we've gotten much better in training, particularly primary care physicians and providers, to look for diabetes and recognize it, and especially pre-diabetes. So it used to be, we thought 50% of diabetics were not even diagnosed. Now we're down to about 3%, so that's good. So about 12% of the population has diabetes. 7th cause of death in the United States. By states, I took some of the states I could remember y'all were from. I couldn't remember all of them. So if you look at Alabama and Mississippi, they are some of the highest, 11.8%, 11.9%. Kentucky, sorry Zane, 11.3%. Oklahoma's right there in the top 5, 10.9%. Texas, 10.8%. Some of you have to look at the makeup. In the South, Alabama and Mississippi, you have a large African American population. In our state, it is largely Native American. Texas would be Hispanic population. Zane, what makes up Kentucky?
Mainly.
What ethnic group would you have?
Like minorities?
Yes.
There's a big Hispanic population in Lexington, Louisville, and
Okay.
I'm not sure about African American. I don't know the stats on that, but mainly Caucasian,
Okay.
especially in eastern and western Kentucky.
Right. So if you look at this picture, I like because it shows you over time, but it shows you the obesity as it is increased. So you look at the lightest colors are less than 14% obesity. You look at the very darkest red, greater than 20%, 6% of the population being categorized as obese, and you can see the diabetes follows right along with it. So we are right there in the deepest red. We're in the top 5 for the heaviest in the country. We're in the top 5 for diabetes as well. Diabetes is not very kind to ethnic groups. So these are the 5 high-risk ethnic groups. So non-Hispanic whites, you can see are 7%. Asian Americans are an up-and-coming group at 9%. Hispanics 12.8%, non-Hispanic blacks 13.2%, American Indians, Alaska Natives 15.9%. Some tribes, like the Pima, are about 50% risk of diabetes in their tribe. And we have some in this state that are nearly that high as well. So one of the things to keep in mind is if you have a practice that has these ethnic groups in it, you need to be at a higher awareness of their risk for prediabetes and diabetes. Another just to show you type 2 epidemic from 1980 up to about 2010. Some of this is because we are better at diagnosing it. And we're in our training of our physicians and our providers is better. So some of it is things that were already there. Diabetes was already there. It's being discovered. The other is just the increasing obesity, decreasing sedentary part. The other is the movement of ethnic groups into the United States. We find that when we track, this is true with Asians, when people abandon, Native Americans have gotten a lot of studies on this as well. When groups abandon their original diets and they adopt a Western diet, we tend to see diabetic rates go up. So some of that is just the changing mix in the United States of our backgrounds. Children are much more being diagnosed. When I was at your age, your point, we never saw kids with type 2. It would just be laughable. We didn't even think it was really started looking for it until people were in their mid to late 40s. I have seen kids at 7 diagnosed with type 2 now, very obese. I have seen kids that are under 10 that are 200 pounds. We had a brother and sister several years ago, it's probably been 10 or 15 years ago now. They were 14 and probably 16, over 300 pounds. Both of them died of renal failure just from huge obesity. So it tends to be familial. I see that in at least the family medicine population. The parents are big, the kids get big. It's because they're of the types of foods they choose and how the lifestyle they choose as well. So let's talk about who gets diabetes. This is really important. I will ask you questions. This will be part of your assessment. Because I want you to recognize that when these folks walk through your door and you're taking care of them, that you have a high sensitivity for testing or for screening these folks for diabetes or prediabetes. So diabetes is a disease of aging. As we get older, the risk of diabetes goes up. So if you look at the 20 or the even 40s and 50s versus the 60s, you see a great increase in the risk of diabetes. About 20% of 80-year-olds have diabetes. So as we age, then that risk goes up. Overweight and sedentary, high risk. I showed you how it parallels with diabetes in different states. So people who don't move or people who are overweight and don't move are at high risk. Family history is really important with type 2. So if you have a parent that has type 2 diabetes, your risk is about 50%. If you have 2 parents, it's about 80%. So I always taught my adult patients with type 2 is tell your children that they are at risk for type 2 and have them advocate for themselves. To be screened and tested. Because if you are a healthy looking young adult, your primary care provider is hardly going to test you for diabetes. They just won't do it. So getting them to advocate, I want to be tested. My parents both have diabetes, I want to be tested until you get symptomatic and then someone is testing you because they have a high suspicion for diabetes. Before people are diagnosed with diabetes, they have probably had the disease for 5 to 10 years. Okay. So there's a lot, now we can find those people much more easily by the way we test. Ethnic origin, Hispanic, Native American, Asian American, African American, Pacific Islanders, very high risk. History of gestational diabetes, I should have changed this. They have, just this year, they've changed they've taken out giving birth to a baby 9 pounds or greater being a risk. It's so common now that they have removed that as a risk factor. But if you have a history of gestational diabetes, then your risk for future type 2 is high. Then there's high blood pressure, high cholesterol. Remember when we talked, I don't remember now what module we're in, I think it's cardiovascular. Where I told you it's like peaks of a iceberg, cardiovascular disease, high cholesterol, diabetes, what else is in there? Hypertension. They all may seem different, but if we look underneath, there's the iceberg. These have a general pathologic basis in insulin resistance, contributes. If you work with heart disease patients, you ought to always be looking for diabetes, always. Often the first time people are diagnosed is when they have a heart attack. So these are all warning. They look separate, but they're actually all just different manifestations of an underlying common pathologic problem. Let's see. So hypertension counts even if you're treated and well controlled. So even if you have attained the goal of treating diabetes and you have hypertension, it's still counted as a risk factor. With HDL, we look at low HDL, so less than 35 in men, I think it's under 50 in women. Higher triglycerides. Higher triglycerides go along with glucose intolerance. Okay, so normal is 150 or below, and so above that is look for the diabetes. If they've had previous impaired glucose numbers, or been told in the past that their blood sugars were a little high. You'll hear patients still use the term, well, my doctor told me I had borderline. There is no such thing. It's an old term and should not be used anymore. My little ears would go up if I heard patients say that, and I'd do more investigating. If they had an A1C of 5.7 or greater in the past, if they're physically inactive, meaning their work related, their job is very sedentary, or they get no exercise beyond that. Women with PCOS have a very high risk of having diabetes, so always be looking for it in them. Other clinical conditions that are associated with insulin resistance, so severe obesity we talked about. Acanthosis nigricans, when Amy Hughes comes to talk to you, she'll show you that skin condition. It correlates with insulin receptor defects. So the presence of acanthosis nigricans, usually in the fold of skin, turns it a real bronzy brown, and it kind of dusts off. It's an odd little skin disease, but look for glucose intolerance in those folks. And then people have a history of cardiovascular disease. Diabetes or glucose intolerance is usually a part of that picture. Questions? So this is the face of people with diabetes. So you see a lot of ethnic groups there. You see age ranges from the very old to the very young. Those kids that's taken at a camp for Native American children with type 2 diabetes, all of those kids have type 2. We talked some about in terms of inheritance, and we're going to focus now and shift to just mostly type 2. Concordance with identical twins is high with type 2. It's about 80%. And if you look at kids with type 1, it's much lower. It's about 50%. So if your identical twin has type 1, your risk is about 50%. If your identical twin has type 2, your risk is about 80%. If your parents have it, you're genetically geared towards it and at risk. With type 2, we can kind of look at it as a triumvirate of the organs that we've already talked about. We have impaired insulin secretion from the pancreas. We have an increase in hepatic glucose production by the liver. And we have decreased glucose uptake by muscle. So that's what they call a triumvirate. That is adding to and is increasing that blood sugar. Like I said, beta cell dysfunction starts way before you see these folks. So it's usually on the average of about 7 to 9 years. You'll see different studies listed in different ways, but probably about a 10 to 15 year decline. So here with impaired glucose tolerance, it's hard for you to find it because on fasting blood sugars, they will look normal. So fasting blood sugars are one of the last symptoms, or impaired or an elevated fasting blood sugar is one of the last symptoms to appear. It's the blood sugars after you eat that usually are the telltale sign. But when you order a blood sugar, most of the time you're getting a fasting. Okay? You tell the patient, come in fasting. You won't usually find these people here with that. So their postprandials will go up. But given enough time in between meals, they can bring their blood sugar back down to normal or near normal. Okay? So that will go on for years. And unless you take a random and you're sensitive to that, what that random number is, you probably will miss these folks. I would tell you if you see anything of 160 and above, even on a random, you should pay attention to that. And we'll talk about after lunch what tests to get to detect these different phases. Around the time of diagnosis, you may find them because you do they come in and you get a random blood sugar. They have no symptoms. These folks usually don't have symptoms at this point. And they're not going to be complaining, but maybe you run a blood sugar and an abnormality pops up. Another place where it may pop up is they come in and they say, my family has diabetes, I want to be tested. Or here's another way it comes to me. I was playing around with my brother-in-law's glucose meter and I did a finger stick and I got 300 and that kind of worried me. Yep, it should. So sometimes I'll get them coming in that way. So the problem is that there has been much decline in that beta cell. So you see that by the time you see them start picking it up on laboratory or they start to become symptomatic, and most of them are not going to be symptomatic until they're out here, they have lost 50% of their beta cell function. Now, that's plenty of function to keep them fairly asymptomatic and doing okay. They won't complain enough or have enough complaints. Or the things that are happening to them are so insidious that they've gotten accustomed to it over time. So the hallmark of and what's thought to occur first in type 2 is resistance. Peripheral tissue resistance. So their muscle, their liver, and fat have become resistant to the effects of insulin. So you can see in a normal cell, 20,000 receptor sites. In an insulin-resistant cell, 5,000. Okay. So their ability to clear glucose out of the bloodstream is diminished. Okay. So that's that is what is thought to be the primary defect. Many think it occurs first in the liver, and then subsequently it shows up with the muscle and the adipose tissue. So what happens is that when that resistance occurs, if you look, this is normal, so this is insulin resistance, this is blood sugar levels, this is insulin production. So in a normal state, those are all in equilibrium. You've got low insulin resistance, you have normal blood sugar levels, and you have normal insulin production. What happens in the prediabetes? So what happens, you've got that insulin resistant going. So what the beta cell will do is it will just produce more insulin. Your blood sugars are higher, must need more insulin, insulin levels go up. So at that cost, usually you can maintain blood sugars in a fairly normal range. So prediabetes, these would be fasting blood sugars between 100 and 125. What's normal? Normal fasting blood sugar is what? 70 to what? 99. Okay. So now we've moved above 100. So blood sugars, that's not a big change over a category from 100 to 125. But what did it cost? Insulin resistance has become very high, so blood sugars stay high. So what does the pancreas do? It pumps out a lot more insulin. So if you were to test these folks and do a C-peptide, you would find very high insulin levels with some maintenance of blood sugars. These folks will not be symptomatic. After a meal, they probably have a lot higher blood sugars than what they have at fasting. When you cross this line, and our diagnostic criteria now is if your blood sugar is 126 or above on at least 2 occasions, then you can be diagnosed with type 2 diabetes. So what happens here over a period of time, this is about a 15-year period, you see that the insulin resistance doesn't go down. If you don't do anything, if you don't change the way you eat, if you don't get more active, if you do not lose weight, then the resistance just stays there. So what happens? Insulin production goes down. Eventually the beta cells will stop responding to a very high level of blood sugar. And so insulin production goes down, blood sugars go up, and that's about the time you will see most of these people. You'll figure them out. Or they'll have so many symptoms that they'll come and they'll complain. Questions about these? Natural history of type 2. I did not put this in your handout. So impaired glucose tolerance, long period of time. But look at what under here, macrovascular complications, those are the cardiovascular complications. They start way back here during those impaired glucose tolerance. That's why it's important to find those people. That's why you look for these other peaks. You look for hypertension will show up long before the diabetes will. Impaired lipid production will show up long before the diabetes will. You start looking for those. People with central adiposity that are advancing in age, 40s, 50s, that don't move around a lot. Those are the people to really pay attention to. African American, Hispanic, Asian, Pacific Islanders, okay? Then you get undiagnosed diabetes, they start to get symptomatic, someone picks it up. Microvascular complications have a higher threshold, so usually above 8% of an A1C. This for microvascular is about a 5.5, so much lower threshold. Then we have known diabetes, and you have the same picture then that I showed you in the other. Here, what I mostly want you to see is that where those complications start. Cardiovascular, much higher, lower threshold. Pay attention, figure them out, and start addressing cardiovascular risk factors. Here's what happens to insulin over time. So this line is the normal release. Okay, first phase release, its target is what? Liver, and it does what? What's the first phase do? What's it cause the liver to do? Stop releasing glucose into the system and start storing it away as glycogen. Second phase, its target is what? Tissues. Okay. So here's what happens in early type 2. You lose the first phase. So what does that mean? What does that mean? If you lose first phase, then what does the liver continue to do? It continues to put glucose into the system early on, early in the disease. Okay? What happens to phase 2?
Tissue resistance.
Tissue resistance is there. You still put out insulin. It's usually not, it depends on where you are. You can have higher insulin levels, but it usually is a more prolonged time period. So instead of returning blood sugars to normal in 2 hours, it may take 4 to 6 to 8 hours. Okay, so it's prolonged and a longer period of insulin production. Look at what happens in late type 2. Type 1, or the phase 1, phase 2 are both diminished. These folks rarely ever stop making insulin. So they usually don't get ketotic. They usually don't get the real big metabolic abnormalities that we see with type 1. They can produce just enough to keep their adipose tissue from breaking down all the time. So they have very diminished, their basal amount goes down, and their ability to respond to a meal is gone. Okay? This is important. We'll use these concepts to figure out how then to design a regimen to treat the abnormalities that have now occurred. So a man by the name of DeFronzo, he is out of Texas, big name in diabetes pathology for a number of decades, came up with this concept of the ominous octet about, 2009. I heard him deliver this at the diabetes meeting right after that, probably 2010 or so. So, ominous octet, what he's saying is that there are multiple organs that are responsible for the resulting hyperglycemia. So you see the decreased incretin effect. That's a fairly new concept in diabetes. Increased lipolysis because of decrease in insulin. Increased glucose reabsorption by the kidneys. Decreased glucose uptake by the muscles raises blood sugar. Neurotransmitter dysfunction in the brain contributes. Increased hepatic glucose production by the liver, big one. Increased glucagon secretion by the pancreas. Impaired insulin secretion by the beta cells. So multiple factors are going awry that are all contributing to hyperglycemia. So our drugs target those different problems. Okay, I didn't put this one in there. This is just a little bit clearer than that last one, just to bring home that beta cell decline is significant by the time you see them. This I've already stated, but it just shows you time frames and how long that all of those defects have been in place or have been progressing by the time you then see them. That's why it's so important to do it beforehand. Identify those risk factors that set them up for developing prediabetes and diabetes early. Because you can, and we'll talk about this later today, you can prevent the onset of diabetes, you can delay it with lifestyle changes and some of the drugs. It's important to identify these folks. So if you go into primary care, internal medicine, pediatrics, this is one of your, should be one of your focuses. Symptoms of diabetes, I'm going to hit real quickly and then we're just about done. So signs of diabetes. I always posted this in the rooms where I practiced so that patients could see it and their family members could see it because we saw more than just diabetes. But these are common symptoms. So they may complain of fatigue all the time. Often patients don't really come in and say, I'm really fatigued, because in type 2 they get used to it. It may be, as you question them, they will talk about it, but it usually is one of the more insidious. So tell me, why are they tired all the time?
They're not taking the energy.
They're not what?
They're not getting the energy into the cell.
They're not getting the energy from what they eat. So even though they're eating, they cannot dispose of all of the energy out of the food that they are getting. Now they've got some insulin and they can maintain weight, they could even gain weight, but they do not get the energy into the cells that they need. Why could they be thirsty? Okay, that's interesting you say that. So patients will put in thirst and urinating more as a vicious cycle. In some ways it is. But let's go back. Why are they thirsty? Thirst, I told you, comes from what increase? Increase in what lab? Osmolality. Why does osmolality go up? What are the determinants of osmolality? Big determinants. Osmotically active agents in the blood. What are the big ones?
Sodium.
Cause water to move. What is it? Sodium. Potassium to a smaller extent. What else? Glucose. We divide it by 18 because this is in millimoles per liter. And then what else? BUN. Okay? So, if sugar goes up, osmolality goes up, thirst goes up. Because your brain's trying to get you to drink more water to dilute it out. Free water will dilute it out. Okay. Why are they going to the bathroom all the time? Why are they urinating? Trying to get it out. Okay, so the kidney has a limited capacity to reabsorb all the sugar it filters. If you exceed that capacity, then it just loses sugar in the urine. Wherever sugar goes, water goes with it. They are married. Okay, and water cannot leave sugar alone. So you pee out all that sugar, so you urinate. Sometimes these folks will be urinating every 15 minutes. You're going to be getting up at night. It'll disturb their sleep. So they urinate a lot, so then they think, well, I'm drinking a lot because I'm going to the bathroom all the time. I'm going to the bathroom all the time because I'm urinating all the time, or because I'm drinking all the time. It's just a vicious cycle of the high sugar. Why is their vision blurry? Pardon?
Retinopathy?
Retinopathy may be in the later stage. Early on, sugar moves into the lens and water follows it. And the lens cannot get rid of sugar. It doesn't have a way to metabolize it. So it takes a while for that to, and it's probably one of the slowest of the symptoms to abate. It can take them 6 to 8 weeks to come back to normal. Why are they hungry?
Their bodies.
They can't use the energy they take in. So this, I think, is one of the most dismissed symptoms of people with diabetes when they see a provider, is they'll tell you, I'm hungry. I eat my meal, and in 2 hours, I'm hungry. And you're sitting there looking at a very overweight person. They are hungry. Those high sugars, if you can get them under control, their appetite will come back to more normal. Now, they still may be overweight, but they're eating a lot because their brain keeps telling them, we're hungry, we don't have enough fuel. What about the sudden weight loss?
The lipolysis.
Okay, so if they're really insulin deficient, they will tear down a lot of their stores, fat, muscle, and they can't utilize all the sugar that they're taking in. So their weight loss comes because of the inadequate energy utilization and the tearing down of stores. Pay attention. When you have it, that's why we always weigh a diabetic, because some of what we do to them will make their weight go up, and we want that because that shows us they've got better insulin activity. But if they are rapidly losing weight, then that is usually a sign of poor blood sugar control. Sexual dysfunction. So high blood sugars are very toxic to nerves. And so this is one of the complaints that can come about because of all the toxicity to different nerves in the organs that innervate. Wounds that won't heal. So the immune system is often affected by uncontrolled blood sugar. And so neuropathically, vascularly, they won't heal as well. Vaginal infections, much more common. You get a lot more sugar in the vaginal milieu, and so it favors the growth of yeast over the normal bacteria. Numbness and tingling of hands and feet, this is, if it's acutely happening, it's usually due to those really high sugars. If it's a long-term problem, it's probably more of a neuropathic change.
I have a quick question.
Yes,
For the always hungry one,
yeah.
how do you differentiate that between someone who's just like a young adult, you know, that isn't necessarily really obese, you know?
Well, looking at situation, looking at weight loss over time, looking at caloric intake, and does it seem to be over and above what they would need? So you would need to be able to kind of estimate or guesstimate what their calories per day were. And if they're still losing weight, then that's a problem. And you've got a high sugar to correlate that with, then that gives you that picture. Any other questions? Okay, this is the foundation. If you can get a good grasp on that, the drugs will make more sense, and how we treat folks are going to really be better. You'll be much better. It'll make sense. Okay, let's take a break, and then Professor Reggio is going to come back and we're going to talk